It's my pleasure to introduce Candelaria de Aro, that she will speak about epidemiology of RADS and COVID RADS. And it is your turn.
In the next few minutes, I will address the topic of epidemiology of ARDS and COVID-19 related ARDS. And well, when they proposed to me the subject of this talk, one of my first thoughts was whether we should really differentiate between ARDS and COVID-19 related ARDS. If we go back to the literature, especially at the beginning of the pandemic, it is true that some authors postulated that we were facing an entity with a completely different behavior than the usual ARDS. And even they adventure the possibility that the management of this disease would also have to be different. This was proposed, for example, by Gattinoni and collaborators, suggesting the presence of two phenotypes, the type L phenotype with the main characteristic of low elastance or high compliance, and the type H phenotype with the characteristic of high elastance or low compliance. If we focus in the histopathology, we have this recent systematic review, including 26 studies and 171 patients, where authors compared COVID-19 patients, H1N1 influenza disease, and SARS infection. And as you can see in this table, the percentage of diffuse alveolar damage is very similar between the three diseases, and also the presence of organizing fibrosis. But we can see a higher incidence of thrombosis in COVID-19 patients and SARS infection compared with H1N1 influenza infection. So at this moment, we know that COVID-19 ARDS has some particular features, as a severe hypoxemia that is excessive, related with the impairment of the respiratory mechanics, especially at the beginning of the disease, ventilation perfusion disorder with shunt and dead space, a vascular component with thrombosis and vasodilatation, a monoorganic failure, also a high respiratory drive, and the presence of a silent or happy hypoxemia, especially at the beginning of the disease, with a low dyspneic feeling. But despite these characteristics, when we face with a COVID-19 patient with severe acute respiratory failure, usually we can see images like this, and actually the expression of COVID-19 ARDS patient fulfills the ARDS criteria of the Berlin definition, with an acute onset, bilateral opacities, a respiratory failure not fully explained by cardiac failure or fluid overload, and all the oxygenation criteria. So probably more than being a completely different disease, COVID-19 related ARDS will depend only on the moment of time in which evaluated, as we can see also in other types of ARDS. So in the early and mild stage, we will see better compliance, ineffective recruitment or atypical PIP response, and probably limited inflammation. But as the time goes by, we can face with worse compliance, usual PIP and prone responses, and probably more inflammation and fibrosis. So from the point of view of the epidemiology, we should be able to find a similar behavior between COVID-19 ARDS and the classical ARDS. And we can take as a reference one of the largest trials in ARDS patients, that is the LungSafe trial. I would like to remember some results of the LungSafe that include more than 2,000 of patients. The mean age was around 61 years old, with a prevalence of men. And one of the main etiologies of ARDS was pneumonia. The duration of invasive mechanical ventilation was around 8 days, and ICU stay 10 days. On the top right panel, you can see the relationship between plateau pressure and tidal volume in the lung-safe patients. And you can see that 2/3 of patients were under the limits of protective mechanical ventilation with a plateau pressure less than 30 and a tidal volume less than 8. And if you can see, the survival decreases with an increase in severity. So a more severe disease, higher mortality. I would also like to remember some ventilatory settings during the first day of ARDS reported in the lung-safe. The mean tidal volume was around 7.6. The mean set PEEP was around 8, and the mean plateau pressure 23. And on the right table, you can see the use of adjuvant therapies that I think that is very interesting and probably is one of the main differences between COVID-19 and classical ARDS. As you can see in this table, the use of neuromuscular blockers in the lung-safe trial was around 21% in all patients, and the recruitment maneuvers was also 21%. The use of composition was very low, only 8% in all patients and only 16% in the severe forms of the disease. And the use of corticosteroids was around 18%. Well, then what happens with COVID-19 ARDS patients? Obviously, the literature at this moment is still limited in a global way, and especially if we focus on the critical ARDS patient. But we have some authors that have reported their experience, and I would like to focus on the main differences found between COVID-19 and patients and classical ARDS. This is a prospective multi-center observational trial conducted in Spain in 36 ICUs, including more than 700 of patients from March until June. And you can see the results or the data recorded for COVID-19 patients and compare with the data recorded from the lung-safe trial. As you can see, the tidal volume is slightly lower in COVID-19 than in lung-safe patients, but the PEEP is higher, the set PEEP is higher in COVID-19 patients, 12 versus 8. Plateau pressure were very similar, 25 and 23. And if you look on the right table, you can see the use of these adjuvant therapies, and you can see how recruitment maneuvers, prone position, and neuromuscular blockers were higher in COVID-19 patients than in the lung-safe trial. The use of ECMO was very similar. It was around 3% in both cohorts. So despite this difference, the 20-day mortality between the two cohorts is very similar, 34% and 32% in COVID-19 ARDS. This is another multi-center prospective observational trials. In this trial, authors compare 300 COVID-19 patients with a cohort of classical ARDS patients obtained from previous data sets, including participants in the lung-safe trial from March until June. And as you can see on the right table, the main difference between the two cohorts is probably that COVID-19 patients have more severity than classical ARDS and also a higher body mass index. And if you look on the right figure, we can see the static compliance measured during the first 24 hours of ICU admission, and COVID-19 patients have a higher static compliance compared with the classical ARDS. And this is another prospective trial. This is an interventional trial where authors compare mechanics of 30 COVID-19 patients with 30 classical ARDS patients obtained from a previous study of recruitability. And all patients were sedated and paralyzed for the measures. And as you can see in the first figure on the left, the compliance, as was reported in previous study, was significantly higher in the COVID-19 patients compared with the non-COVID patients. But there were no difference in the driving pressure and in the recruitment ratio between both cohorts. Then authors set two levels of PEEP, a low PEEP and high PEEP level in a sequential order, and they evaluated the oxygenation and the compliance. And as you can see on the right figure, there are an improvement in oxygenation at level higher of PEEP in both cohorts, but this increase or this improvement was significantly higher in the COVID-19 patients. But if we look on the respiratory system compliance on the right, you can see that there are an improvement in the compliance, but it's only significant in the non-COVID patients. So with these results, we can conclude that probably the improvement in oxygenation in the non-COVID cohort is related with this improvement in the compliance, but probably we should look for another reasons of the improvement in oxygenation in COVID-19 patients, not related with the improvement in the compliance. Well, to conclude, I would like to highlight that patients with COVID-19 associated ARDS have a form of injury that in many aspects is similar to that of those with ARDS unrelated to COVID-19, that the physiological differences found between COVID-19 patients and ARDS from other etiologies appear clinically negligible, that there are differences in the management with COVID-19 patients and classical ARDS, especially with the use of adjuvant therapies, and that COVID-19 patients have similar mortality than non-COVID ARDS patients. Thank you very much for your attention.
Thank you for inviting me. Here are my disclosures. And first, a brief talk that Cande has just reviewed now about the definition of ARDS, which is an acute onset of respiratory failure with different levels of hypoxemia. The timing is within 1 week after the first onset. Then there are bilateral opacities and edema, and the term acute lung injury after this definition was only used for experimental models. The definition of ARDS presents some lags, such as the fact that diffuse alveolar damage does not clearly correlate with this definition, and the fact that there is a heterogeneous etiology of ARDS, and that there is not a specific biomarker able to identify this syndrome. So the incidence of this syndrome is between 10 to 86 cases for 100 person year. It has this variability because it is difficult to predict, and because of demographic, cultural, genetic, economical, or healthcare criteria differences. The mortality still remains high, about 40%. And the patients that survive present physical, mental, and quality of life impairment. So the causes can be direct, such as pneumonia or the aspiration of artistic contents, between others, or indirect, such as sepsis or trauma. The actual therapies are mainly supportive, with mechanical ventilation, prone positioning, and neuromuscular blockade, between others. And there is a lack of therapies focused in the pathophysiology of ARDS. So the normal lung is formed by an alveolar epithelial membrane. In the epithelium, there are alveolar type 1 cells and alveolar type 2 cells, which are the mother cells of the alveolar lung, and are the ones that produce immunological functions and secrete surfactant. Moreover, in the alveolar space, there are alveolar macrophages that are not activated. So when there is an injury, the alveolar epithelium and endothelium become damaged, releasing pro-inflammatory mediators and procoagulant mediators, And this leads to the breakage of these barriers because there is a lack of tight junctions, and all this induces to the permeability, leading to protein-rich edema in the alveolar space and also the entrance of pre-inflammatory cells. This further increases the injury. So Raquel Herrero and colleagues proved that fast-induced apoptosis increased permeability through the diminution of tight junctions. In here, we can see that they administered fast in wild-type animals, and it reduced the occludin levels in the protein membranes. And in animals lacking fast receptor, when they administered fast, the levels of occludin were reverted, and there were found the same levels that in control animals. The same happened when they evaluated zonulooccludens 1, another tight junction, and those levels were correlated with the prisons in the lung sections, finding decreased detection of occludin and zonulooccludens 1 in the injured animals with FAST. This further correlate with increased apoptosis. They found increased tunnel positive cells, which indicates the breakage of DNA strands in animals injured with FAST, but not in animals that were deficient for FAST receptor. And also the same happened with caspase-3 activity. The levels of the breakage of DNA further correlated with the presence of occludin. Moreover, in autopsies of patients with ARDS, they found increased permeability and detection of big plasma proteins, EGM in lung tissue. So, moreover, ARDS can be associated to mechanical ventilation induced lung injury, because there is an increase of pro-inflammatory mediators, and also there is an impairment of the sodium channels. So there are different pathways, which are pro-inflammatory pathways, which are involved in ARDS, which can be induced by external or internal factors. This leads to the activation of MAPKS and NF-kappa beta, leading to the transcription of nuclear factors that increase pro-inflammatory cytokines at the gene molecules, and also chemokines. So we can see that mitochondrial DNA is a molecular part that was associated, that is associated in plasma with increased injury, because it is found in plasma patients of severe trauma. So it is higher in also in non-survivors patients. So one of the proposed therapies, because we can see that ARDS is a complex syndrome, and one proposed therapy that targets some of the mechanisms of this syndrome is mesenchymal stem cells. They have been proved to act on inflammation, also to decrease the permeability through producing ameliorations on the epithelial and endothelial cells, and also it improves the clearance of the edema, And moreover, it regulates the phagocytosis of monocytes. So in our laboratory, we compare the effects of alveolar type 2 cells, which are the mother cells of the lung, and mesenchymal stem cells in a model of acute lung injury. And we found that both cell types were able to produce ameliorations in lung tissue sections. We can see that the injured animal presents more pro-inflammatory cells and increased hyperplasia, and that this injury is reverted in the animals treated with alveolar type 2 cells and mesenchymal stem cells. Moreover, both cell types were able to reduce the levels of neutrophils and macrophages filtered into the lung, and this correlated with pro-inflammatory levels of lung tissue with a decreased interferon, interleukin-1 beta, and interleukin-6 when administering both cell types. This also correlated with lower levels of the mediators of monocyte recruitment. Also, well, inflammation has been found to be related with coagulation. There are different mediators of the coagulation pathway that are released by the alveolar cell types of the alveoli, such as endothelial and epithelial cells, and this leads to an increase of the of tissue factor, leading to procoagulant levels and decreased fibrinolytic activity. These factors are directly related to pro-inflammatory mediators, and also the increase of pro-inflammatory mediators leads to increased levels of tissue factor. This direct link is mediated by protein-activated receptors, which are present in immune cells, platelets, and endothelial cells. And when they are activated by those thrombotic factors, this leads to increased endothelial dysfunction, higher levels of pro-inflammatory mediators, and platelet recruitment. But this further increases the levels of procoagulants and reduces anticoagulants. So we demonstrated that there was a direct link of inflammation and coagulation in alveolar type 2 cells isolated from pulmonary lungs. We found that when administering heparin in injured cells, there was a reduction of pro-inflammatory mediators in those cells, and the same happened when we administered antithrombin. Moreover, there were increased levels of tight junctions in those cells when administering antithrombin. Moreover, we observed these effects in vivo. We injured the animals with lipopolysaccharide, and after 2 hours, we administered antithrombin or antithrombin together with heparin as a treatment. And this, well, we found that there were lower levels of proteins in the bronchoalveolar lavage of treated animals, and also there were decreased levels of pro-inflammatory mediators and procoagulant mediators in lung tissue. This also demonstrates that there is a direct link of inflammation and coagulation. So, well, we can see that ARDS is a complex syndrome. There are a lot of factors that influence in this syndrome, and because of that, there is a need to find new pharmacological therapies able to combat all the mechanisms involved in this syndrome. Moreover, we should move towards personalized medicine because of the heterogeneity of these patients. Also, we need to understand better which are the fundamental mechanisms and pathways that are involved in ARDS. And all these will let us to improve the diagnostic and administer preventive and therapeutic strategies. So thank you very much for your.
Thank you very much, Luis, and everyone in the organization of the World Day of Critical Lung for the invitation. And I'm going to talk about the personalized medicine in patient-ventilator interactions. So first of all, I have nothing to declare any conflict of interest regarding this topic in this session. So what about here? So first of all, we need to focus on what we have learned in the past 20 years about patient-ventilator interaction and exactly where are we right now regarding this topic. So in this small timeline, first we have the recognition of the phenomenon, then we have the visual identification and quantification. Here we're talking about the first studies of Tobin, Sasson, Parthasarati, and the early 2000s and at the end of the 90s. Then we have the first studies of the clinical consequences of this description. So in the last 10 years, we are moving towards another direction, which is the automated and non-invasive detection of asynchrony, which is made by dedicated software, which are some of them in the market. And then we have 2 or 3 more steps forward to the personalized medicine in this topic, which is first the machine learning methods to detect, classify, and quantify them, as was made previously by visual detection. And then we have the personalized threshold on what is an issue, what could be a problem, but not to all patients, but to every given patient. And finally, the last step at this time is the personalized prediction of events. So by this time, we should ask ourselves, is there another clinical consequence that we could learn from this point onwards? So the talk would be from the green arrow and on about the taking from machine learning to prediction. So first of all, this is a very nice study, which was published a couple of years ago to replicate the human experience through machine learning. They used 5 experts to review 1,400 breaths from 11 patients, and they apply random forest, which is a machine learning technique, and cross-validation methods to quantify them. What they found out is that, as you can see, the sensitivity, specificity, and so on, they had really, really good numbers to replicate the human experience through this method. Another one going in that direction was a study by Peter Sotile, which improved this one, the previous that I have talked. The expert here reviewed 2,500 breaths, and differently to the other one, they applied 3 different techniques of machine learning. They applied random forest, naive Bayes, and AdaBoost. I will not talk about them. And then they tested this result in a huge database of almost 4 million breaths of 62 patients. These are the first result of which of the 3 methods and the metrics of them. As we can see, the use of naive Bayes really have really good numbers in detecting different types of asynchrony. So they move forward with this method. I'm sorry, here I see the picture is bad quality, but take a look at the accuracy. They find out that the double trigger breath and the flow limited breath, by applying this technique, they really detect with high accuracy. And also detect with high accuracy, which is a normal breath, which is a really important issue to detect what is normal. They don't have really good numbers with the other type of asynchrony, but this study was a really good step forward into how to apply and how to study using machine learning technique in the detection of asynchrony. Then we have another recent study that applied something different, which is a study by Casagrande. They study 1,000 breaths, and what they study is the sub-breath loop. This is the description. I'm going to show an image then to what is the detection of the sub-breath loop as an ineffective effort, and then they test it in another different data set. This is in the left panel, we have a normal pressure flow loop, and what they're trying to detect through machine learning is this small loop. Whenever this happens, this is an ineffective effort. So they applied also a naive Bayes, which is the method applied by Peter Sotile to detect this. And they also found, and which is very interesting, which it has not been done before, is the selection of the future. This is a machine learning technique, which is future selection. They allow the algorithm to detect which variables could be the most important one to study. In here in table 1, except from the red box in the bottom, all of the variables were selected by the algorithm. So this is really machine learning. What you don't give the input and let the technique to future select which variables could be the most important one to study. This is what they have done. All these variables were selected by the algorithm, except from the last 2 that were selected a priori by the researchers to improve the outcome. As we can see, they have really, really good results, an accuracy of almost 0.98, which is very high in detecting that loop. And then we have, moving to the personalized third score, we have an old, well, not that old, but almost 10 years ago, study by Gutierrez and colleagues, which makes something different, completely different. They studied the spectral analysis of the airway flow. And what exactly is that? They begin with studying 110 patients with 2-hour tracing of only airway flow. They studied the frequency spectrum of the flow transforming through a Fourier transformation and trying to determine in an automated and personalized way the asynchrony index. This is some graph that in order to explain what they have done. First, in the panel A, we have the spectrum of frequency of the signal of flow, and which is a synchronous breadth. As you can see, we have pretty much regularity in all of the frequencies. Then in panel B, we have, which is an asynchronous breadth. We can see that between the spectrum of frequency between 20 and 40, we can see the huge variability in all the spectrum. And then in panel C is a very graphical one when we can see a patient going from synchrony to an asynchrony. So this is the first thing they have done, and very interesting is this. This is the first study to study personalized threshold. They make a sensitivity analysis to determine which is the best cutoff point to detect an asynchrony index of more than 10 in every given patient. And they found out that a 43% cutoff in this spectrum analysis could detect an asynchrony index of more than 10% with a sensitivity and specificity of 0.86. So this is a really, really good thing to begin to moving toward personalization and to determine threshold. This is a study made by our group, which is going in the same direction to study threshold in a personalized way by applying a different technique. In this time, we apply a nonlinear method of sample entropy in order to studying the flow and the pressure signal in order to detect irregularity and complexity. We define what the complex patient ventilator interaction by incrementing the respiratory rate and in the presence of asynchrony in a moving window of 3 minutes. But most important, we are trying to determine personalized changes from own patient values. This is what we're trying to do. In the first 2 images in the top, we have changes in the free respiratory rate in flow and pressure. And then we have different types of asynchronies, flow and pressure again, and then when it happen all together. What we create is a new signal, which is here. This is the sample entropy signal. When everything is going right, there's no complexity or irregularity. We can see that everything's going well. Then we have a small change and going back again to baseline. And this is what we are trying to detect, which is the best threshold to determine when the things change. And then in the third panel, we have when things changing all the time and going up again. This is what we are trying to detect. So first of all, we have to determine 4 things. I'm sorry. We study the flow and the airway pressure. We study the mean changes, and we also study the maximum changes. And we have different threshold values here in the bottom, and in the left side, different parameters of selection of sample entropy. All this graph is meant to show how to determine in a personalized way which are the best thresholds and which are the best way to study if we study the mean or the maximum change, and which are the variables that we should take into consideration. I don't know if you can see, but there are small black dots in flow and pressure, and these are the results. We have found that the best cutoff values either way to flow and pressure is in 25% of change from baseline, maximum change, and 35% if we are taking into consideration airway pressure. These are the results. In the white box plot, we have the optimization process, but take a look at the gray ones, which is the validation process. There's a sensitivity with sensitivity and specificity, which is almost all above 0.90, and the accuracy of both taking flow or pressure changes is almost above 90. So this is our first study to determine personalized changes and which cutoff should be taken into consideration. Finally, we also have a very interesting work, which is the last step in order to predict events. So this is another study coming from our group. This is a very huge study, and I'm trying to make it easy. We have taken into consideration almost 10.5 million breaths from 51 patients. And the asynchronous were detected and classified by a validated software. And what we use here is the hidden Markov model. Hidden Markov model is another machine learning of unsupervised learning that is able to detect changes in states. We are from one state and moving toward to another state of different events. So what we can do, the Markov model, is to automatically detect what we name low risk state, which is our low frequency events. Events are the asynchronous, to high risk events, to high risk states, I'm sorry. So we identify 4 different states, moving from low risk, which is set 1, to high risk, which is set 4. And the main outcome is to predict the probability of transition from one step to another. So what we know is what we have and where we are in asynchronous state, and we're trying to predict if we are in this point, what could happen in the next 15 or 25 minutes. So this is the distribution. First, the probabilities. In green, we have the set 1 state, which is a low frequency state, which is, we can see it's the most frequent one. Patients do not have asynchronous all the time, so it's not difficult to think that the set 1 state is the most present one. And then we have the set 4, which is the red one, which is a high asynchronous state. And this is the prediction. So we can see in the left panel, the 4th state, and the right panel, where they could be on the next 15 minutes. As we can see, the black arrows, as when they get thicker, they represent the higher probability. And we can see that all the states tend to be the same again, 15 or 25 minutes later. So the first conclusion of this is that large shifts from one state to another are pretty much uncommon. That means that a patient is being in set 1 is really highly improbable to move from set 1 to set 4. That means that if they don't have as much as asynchrony, it's pretty much unlikely that in the next 15 to 25 minutes have a huge amount of asynchrony. On the other hand, if they are in a high state of asynchrony, which is set 4, it's highly probable to remain in that state, that risks then solving the problem. So these are the main conclusion in this study, that whenever a patient enters into a high frequency state, which is set 4, it's highly likely to remain in that state unless we do something. So to conclude, I think we are in time. There are some take-home messages that first of all, the automatic detection of asynchrony based on machine learning techniques is feasible. The personalized threshold of detection showed to be accurate in some studies, and the prediction of future events are a promising step. But the metrics, we need some more metrics for all kind of asynchronous. Right now, we only have metrics for some ineffective effort and double triggering, but we need to do the same in all kind of asynchronous. We also need external validation in large data sets. Right now, we only have some study made. Even they have some cross-validation, we are really good techniques for validating. We need to do the same in some external data set. And we need to know the clinical implication of this precision medicine. So right now, we know that we can do it, but we really don't know if we do it, gonna be a consequence, gonna be better, for better or worse. So this is another step forward. That's it. Thank you.
I will first to ask a question for each of you, and then I will go to the chat whether there are questions from the audience. And And well, in fact, I have a lot of questions, but my first questions will be for Cande. Cande, I mean, you and me, we work together, okay? And we know, and we share sometimes knowledge, and we share also questions. But my question is, looking at your presentation, that I found it particularly useful to understand RADS before COVID and RADS, COVID RADS, you said that maybe these two entities are the same. But look at that, mortality is the same, but adjunctive therapies in COVID RADS, we use adjunctive therapies, I mean more than 80% myorelaxants, more than 80% prone position, and recruitment maneuvers. Recruitment maneuvers, a lot of discussion about that. But then, why are you saying these two are the same when the adjunct therapies that we know that have an influence on the prognosis are far higher used in COVID RADS?
Well, I think that both diseases are the same, but it's a fact that COVID-19 ARDS probably have more severity than the classical ARDS. So more of these adjuvant therapies are usually used in the severe cases of ARDS. So I think that with COVID-19, we are in the severe spectrum of this disease. And this is about probably the use of recruitment maneuvers, because we have high levels of hypoxemia in COVID-19 patients, and also the prone position that is indicated in these severe cases. For me, it's surprising the low use of prone position reported in the lung-safe trial in the severe cases. On the other side, I think that is the same severe, but it has some particular features that make more difficult the ventilation of these patients. And usually these patients present more asynchronous than other patients, and probably the use of higher doses of sedation and neuromuscular blockers is more related with a poor patient ventilator interaction more than to be in front of a severe disease or another disease.
Okay, thank you, Cande. I will be back to you later on. So my next question is for Marta. Marta is here with me, and Marta, you work in the group together with Antonio Artigas and other people that you are experts in coagulation in RADS. You have developed several, animal models showing interesting data on coagulation in RADS. Now my question is, what are the differences between alterations in coagulation in RADS and in COVID-19 RADS? Because it seems that in COVID-19, all the alterations in coagulation, like microthrombosis, starts very earlier, which perhaps is a little bit different of the classic RADS. What do you think?
They are the most severe patients of ARDS, and there is a huge storm of pro-inflammatory cytokines, but also, which is the main feature, is that there are increased the DMARD levels, also fibrinogen, and that the lengthening of the coagulation time also is increased. Moreover, it is characterized because there are lower platelet counts. So yes, I think that there are features in common, but both inflammation and coagulation are higher in those patients.
Okay. Marta, let me ask you something. Why? So this means that we should start very earlier anticoagulation therapies, maybe locally in the lung. Let's say, nebulized heparin or things that you have tested in animals.
Well, I think that it would be nice. In fact, now, Dr. Artigas has a talk later on about nebulized therapies in those patients. Well, nebulized anticoagulant therapies. And yes, given that they have anti-inflammatory and anticoagulant effects, but also it have improved that they are also antimicrobial and antiviral, and that could be a good option for those patients.
Okay, Marta, thank you. Now, Jose, thank you for your talk. Your talk, it's a kind of, you have your microphone silenced, okay, mute. Okay, your talk is a kind of futuristic talk, because in 13 minutes to explain the Gutierrez, the Casagrande, the Sotil, the Markov paper, and the entropy paper, you know, it tells me that we as physicians probably need to work in the future with data scientists, computer science, software engineering, I mean, in trying to solve some problems at the bedside. So my issue is, how do you, I mean, envision how we will work with all these algorithms at the bedside, and we as physicians, you know what I mean? It's we as physicians work with the patients, but do we need all these algorithms and machine learning all the time? Do we need this only, I mean, to interpret data in the computer? Or how all this will help our work really at the bedside to solve problems like poor patient ventilator interaction, unplanned extubations, all these issues that really worries us, we as physicians at bedside.
Well, yes, we have to think that we are moving in the first steps of some translational medicine, that most of the time this issue takes some time to apply from the bench to the bedside. I think that we're moving really, really fast from bench to bedside in these issues, given the technology most of all. So yes, there's a huge gap between the data science engineering and then to applied medicine. I think that in the possible next 5 to no more than 10 years, most of these discoveries that right now are from the bench will move towards from application. That's why I said at the end of the talk that future direction is the clinical implication of all of these things, because right now we don't know. We have a lot of data and we really need to apply them into some clinical practice. I think that what Marta talked before has to do with it. Marta has been studying RDS from the bench, but RDS has been looking at, we are searching from RDS since the late 70s. So we have almost 50 years of research from RDS. And right now we are in the early phases of the first 10 years of machine learning and artificial intelligence in this topic. So then our next step is to take all this knowledge and transform it into clinical, basic, and applied medicine. So this is the next step.
Jose, will this substitute physicians?
Well, that's a huge fear to everyone who is doing this. I really don't think so. I really don't think that from now on, any given technology could replace human thinking. But what it can do is to facilitate and to make some decision making more secure. I don't know. I don't think that it will be replaced, but we can have some more information to diminish the speculation phase that we have a lot in medicine. We have a lot of speculation, what we call experience. That experience could traduce into data, and that data could be used into some decision-making algorithms. So it won't replace us. So I think that we have a job for the next couple of years yet. But what it will happen is to reduce the uncertainty in many topics.
Okay. So we have time for 1 or 2 questions more. So the next question, since in the chat there is nothing, when I look at that, now let me see the chat. No, not nothing there yet. So it's for Cande. Cande, my question relates a little bit with the, I have to, okay. Cande, since you are here, why, I mean, tell a little bit us about phenotypes in RADS. Now there are descriptions in some phenotypes in RADS before COVID. Do you think this will be important to characterize those phenotypes in COVID RADS? And if you have any information, if this is different, compare the two.
I have no information. I don't know if there is any study in these phenotypes from the classical ARDS now in the COVID-19 ARDS. obviously, I think that all information is important, and obviously all information could help the physicians to adapt the treatment or to look for the best treatment for the patient. Actually, at the bedside, we only have the oxygenation criterion, the mechanics, and we try to adapt and to use the more protective mechanical ventilation for these patients. But for sure, if we have more experience with the different phenotypes and the behaviors of these phenotypes, probably we can move to a more personalized treatment of these patients.
Okay, so we have, perhaps will be the final question now because it's 2 minutes left, but I have the question is for Marta. And the question reads like this: do you think heparin has double effect as it is an anti-inflammatory drug, so damps the inflammatory cascade and also improves flow if patients are resuscitated adequately?
I think yes. It has been proved that nebulized heparin in mechanical ventilation patients produce ameliorations, and now we will like to try this in patients with spontaneous respiration also.
Okay. So it's 1 minute left. I think we finished the session here. I would like to thank Cande, Marta, and Jose these excellent presentations, an excellent discussion about cutting edge issues nowadays. So thank you very much, and Orville, it's time, I think, to move to the next part of this long day meeting. Thank you also to the audience, around the world, to be with us in this non-profit, an absolutely free, event just to share knowledge, by the pleasure to share knowledge among you. Thank you very much.
Thank you.